Welcome, everyone, and thank you so much for joining us this afternoon. My name is Rachel Smythe. I'm the Education Coordinator at the Caregiver Resource Center OC. Since 1988, the Caregiver Resource Center OC is a trusted partner for Orange County families who are coping with the physical, emotional, and financial responsibilities of caregiving. And by providing families with individualized supportive services, the Caregiver Resource Center stands apart as the only Orange County agency focusing exclusively on the needs of caregivers who are coping with a loved one's chronic illness. The Caregiver Resource Center provides family consultation, support groups, assessment and care planning, counseling, respite planning, and community education. Here at the Caregiver Resource Center OC, we host a live stream the last Monday of each month from 3 to 3:30 p.m. And this afternoon, you've joined us for What is Palliative Care? And today I'm joined by two members of the palliative care team from our host agency, Providence St. Jude Medical Center, Stephanie, who's a nurse practitioner, and Anna Marie, who is a licensed clinical social worker. I'd like to give you both a chance to introduce yourself before we jump in. And audience, whether you've joined us on Facebook or on YouTube, please feel free to ask questions or share comments with us throughout the live stream. But with that, I'll go ahead and I'll turn it over to you both to introduce yourself, your role, and the name of the agency that you work with.
Hi, my name is Anna Marie Rosser, and I am a licensed clinical social worker here with Providence St. Jude Medical Center on the inpatient palliative care team. As a social worker, I worked with families and patients to address any sort of emotional, spiritual distress, and work to work through any legal, ethical, moral issues, and constantly assessing for what programs or resources both patient and family may qualify for and what may benefit from.
Thank you. And then Stephanie?
And my name is Stephanie Hua. I'm a nurse practitioner with the inpatient palliative care team at Providence St. Jude Medical Center. I'm fellowship trained and I'm board certified in hospice and palliative care.
Thank you both again for being here. It's so nice to see both of you, and we'll just go ahead and jump right in. And the first question for Anna Marie is, so what is palliative care?
Palliative care is a specialty service like cardiology for patients in active treatment with some sort of serious illness such as COPD, cancer, heart failure, who need more assistance than can be provided by a primary care team. So palliative care helps that you understand and help manage your treatments better and create a plan with dealing with medical crisis. With our palliative care team, you have better control over bothersome symptoms such as pain, shortness of breath, and nausea.
Thank you. And then Stephanie, so Anna Marie just shared a little bit about what palliative care is. And so what types of services does palliative care consist of? What's included in that?
Okay, so services provided by the palliative care team include symptom management, goals of care discussions, which is kind of individualizing your treatment plan. We provide anticipatory guidance on your illness, and we help with advanced care planning, which are documents that delineate your healthcare wishes. We also have social workers and chaplains who can help provide emotional and spiritual support. Our social workers are also excellent at helping patients connect with community resources and also to help our patients and families process emotions, thoughts, and feelings to provide support and help with medical decision making. And together as a team, we help also with safety net planning.
Great. And so Anna Marie shared that palliative care is helpful for someone who maybe their regular primary care is just really not adequate. It's not enough support. And so with palliative care, how often is a palliative care provider or somebody on the team seeing your loved one? How often does that happen?
So in the inpatient hospital setting, you'll be seen by either a physician, a nurse practitioner, a registered nurse, a social worker, or a spiritual chaplain on an as-needed basis, which means it would be kind of dependent on how your hospitalization goes. Patients who are more seriously ill or have more symptoms that need medication adjustments will be seen more often. In the outpatient setting, our patients are generally seen once a month by a provider. In just like inpatient visits can be more or less frequent depending on the stability of illness and symptoms.
Okay.
So there is some flexibility here.
Right. No, that's very helpful. And you mentioned something too that I definitely want to come back to, which is inpatient palliative care versus at home.
Mhm.
So you kind of brought that up to in my mind. So I want to make sure I talk to you about that too. But Anna Marie, you kind of mentioned some of these reasons, but typically, what are some of the most common reasons someone might receive
Mhm.
palliative care?
There's a few different ones. One is definitely a help with a patient's either pain or symptom management. We're also there to help talking about what your preferences are as far as who's going to be your surrogate decision maker. We're talking about advanced care planning, which includes filling out an advanced healthcare directive that talks about your healthcare wishes. It designates a spokesperson for you if someone is unable to. It also talks about the post form, which is a medical order about your medical wishes. And we're also there, especially for the physicians and providers, to talk about education about your disease process and what that can look like moving forward with or without treatment. For the social workers and other team members, we're there to help again to provide some of that emotional, spiritual support that goes along with all these treatments and going through their illness process. We're also again connecting to any sort of resources in the community that you might be eligible for, whether that's caregiving or financial services that could be connect with. We're also connecting and helping making sure you're maintaining safe at home. So we're doing safety net planning and we're assessing for what kind of medical equipment you might need. If someone needs caregiver support at home, medication needs. And then we're also having those hard conversations, both inpatient and outpatient, about your chronic illness, what your medical wishes are for healthcare, and what's most important to you as the patient.
Sounds like that'd be very helpful when somebody's going through so much and not really knowing what their health will look like. To have that safety net and that support from you all seems very, very helpful.
Mhm.
Um, and so, to me, it definitely seems like a great thing. And so I'm wondering, Stephanie, if you wouldn't mind, what are some of the benefits for a
Mhm.
family or a care receiver or patient that come along with palliative care? What would be some helpful things, I guess?
So there's a lot of different benefits, but one of them that stands out to me is the assistance with disease preparedness. And not just for the patient, but also for the family, because we see the family as an extension of the patient. And it's really crucial to have everyone on the same page when it comes to a plan of care. We want to make sure both the patient and the family understand the disease process, what care looks like moving forward, and what potential obstacles the patient and families may face, and kind of a good plan to address that. The other benefit that I really think is important is when it comes to your health, sometimes there are events that are out of your control, and we know that we cannot control every aspect of your care. But palliative care wants to make sure that if there are any choices, that you have a say in them. We see you as a person and not as a number, and we want to help personalize your care to ensure that your choices help with what is actually important to you.
Yeah, that's very helpful, and what a great and holistic way of viewing someone so that they have the best health outcomes, whatever that looks like for them. Um, and then before I do forget about that, I do want to ask. So I know you both work inpatient palliative care.
Mhm.
So what would be the reason someone ends up um, using palliative care services inpatient versus at home? And then is there a typical length of stay inpatient palliative care? And either one of you, whoever
Uh,
feels comfortable answering that one.
As far as like a length of stay with palliative care on the inpatient side, it's kind of as needed. So if we're still having ongoing conversations about medical wishes, goals of care, sometimes we're doing family meetings. If there's any sort of important medical information that will help with decision making, then um, depending on what your needs are, sometimes we do team up together, whether it's Stephanie as a nurse practitioner and myself as a social worker go together to provide support for the family and patient. Sometimes a patient is better seen by our chaplain for some sort of spiritual distress. But it's kind of what Stephanie said. There's a lot of flexibility. Sometimes we see patients and goals are clear and we kind of sign off the case, but at any point in time during their hospitalization, if something changes, we're able to be reconsulted or come back on and see what's going on if something's changed.
That's helpful. And then is there any reason somebody would maybe, is it just because they were already hospitalized but happened to be followed by palliative care, or what would be the reason someone's in the hospital versus palliative care at home?
In the hospital, it depends. So if patients are being seen on the outpatient side, whether they're established with our clinic and they're seeing our physician, PA, or nurse practitioner, generally they do like to have continuity of care. So they will let us know if the patients are in the hospital, and either they'll come and see the patients personally, or one of us will follow up if they don't have the time or they're seeing their clinic patients. I'm sorry, was the other part of your question versus home?
No worries. Just because typically when I've thought of palliative care, sometimes I'll think of somebody who's residing in the community and they're also connected with palliative care. But then also, palliative care is a whole department within the hospital. And so just kind of was wondering what the differentiation between the two would be, or why
Mhm.
somebody might be inpatient versus at home. But it sounds like maybe if their situation's a bit more acute or
Mhm.
needs a higher level, then typically they might end up in the hospital and being seen by your team. And then maybe when
Mhm.
they're a bit better, then as they get discharged, they're followed by the clinic, is what it sounds like.
Yeah, we're a consult-based team, so anyone could consult us in the hospital, but we do kind of evaluate whether the patient has a palliative diagnosis and whether we're
Mm.
being seen for a palliative need. So sometimes that's a goals of care conversation, they need pain or symptom management, sometimes it's advanced care planning, um, but usually it's either a nurse or physician that's consulting us for a specific reason. But yes, we do evaluate to see if our patients would qualify or they would be a good fit for our clinic so that, again, they're having that continuity of care once they leave the hospital. Our physician, PA, or NP, or other social worker can help bridge and follow them out in the community setting.
Okay.
And the
Yeah, no,
in
that's
and
very
the in
helpful.
oh,
Oh,
sorry.
go ahead,
And the
Stephanie.
inverse, yeah, sorry. The inverse is true as well. We have patients who were not ill enough to be in the hospital, but they needed some symptoms managed in the clinic, and then they actually unfortunately got worse and they needed to go to the hospital. And so the team members in the clinic will actually reach out to us. So we're kind of aware of the circumstances, and we try and pick up and make sure that everything's coordinated.
Okay. Yeah, thank you for sharing that. And so you kind of brought this up too, at least on the inpatient side, having a
Mhm.
consult from, a physician or nurse practitioner. So in general, how would somebody receive or get to receiving palliative care? Do they have to have a referral, or what would the process be
Mhm.
like if someone's listening to this and they, based on what you've shared so far, it sounds like either for themselves or their loved one, if they're a caregiver, that they would benefit from palliative care. So how would they get connected?
So on the outpatient end, I would recommend talking with your primary care provider. Both you and your family can actually request a palliative care consult, and you can get a referral there. In the inpatient, it would be your hospitalist, which is kind of the main physician in charge of your care. And same thing there, it can be from the patient and it can be from the family.
Great. Um, and then when it comes to, and it might be different, inpatient versus out
Mhm.
in the community, but if I have palliative care, will I have the same providers each time? Will I have the same social
Mhm.
worker, same nurse practitioner? How will
Mhm.
that part of it work?
At least when you're in our outpatient clinic, once you're established with a provider, we generally try to continue to follow and support throughout that process. So it's generally you're seen by the same provider. On the inpatient setting, we do have an interdisciplinary team. So we have our social workers, our chaplain, our nurse practitioner, our nurses. Um, so depending on what the needs are, so sometimes I'll go in and see a patient and we're addressing goals of care, but maybe there's a lot of um, medical questions that they have and it's a little bit out of my scope, and so I'll pull in a provider to kind of help address some of those medical terminology or disease process, and vice versa. If a nurse practitioner feels like a patient or family would benefit from a social worker or a chaplain support, then again we'll kind of buddy up. But we generally try to kind of keep, again, continuity of care even on the inpatient setting, to kind of, as long as there's a need for us to continue to see a patient, we do our best to keep following the same patient unless there are other disciplines that need to come in and help support.
That sounds good. Thank you. And then Stephanie, if you have palliative care, are you still able to see your regular doctors, regular specialists that you've already been going to? How does that work in terms of your team working with somebody's primary care team?
Like we mentioned earlier, we're a specialty team, and we're just here to provide an extra layer of support to the patient and family and their medical team. Usually we work in conjunction with your healthcare providers as well. It's more of a collaborative effort as opposed to something being separated.
Okay. Yeah, no, I think that's great too, because sometimes I think there's miscommunications, or
Mhm.
people just don't necessarily know as much about palliative care as we'd all like to. And so knowing that it's this collaborative approach, I think is very, very helpful. And Anna Marie,
Mhm.
so of course, I'm sure you get a lot of questions about the differences with hospice and palliative care and
Mhm.
regular medical care. And we'll get to some of those questions too. But I'm just wondering, with palliative care, how accessible is the palliative care
Mhm.
team to someone if they need help in the middle of the night? What would you all recommend in terms of getting support? Does that go to
Mhm.
regular emergency services? What would that look like?
Yeah, so at least at the clinics, the outpatient clinics, so they are open during regular business hours. So if you're having a medical emergency, we would recommend calling 911. Now, if it's not an emergency, you can always call the office, leave a message, and the office will contact you the next business day. Certainly will kind of help connect you to the support that you need. But if it is a medical emergency, we're not going to be available in the middle of the night for any sort of emergency needs that you have.
Okay. Okay, that's good to know. And then, Stephanie, and this one is, I know with hospice, this does stop. So I'm wondering if when you have palliative care, if you are more being seen in the clinics and you're not in the hospital. And I think I might know the answer to this based on our conversation so far, but just to check, if I have palliative care and I'm at home and I go into the hospital, does my palliative care services stop, or how does that work? Would it just end up, getting connected with you all there? Or what if I have palliative care outside of St. Jude? It's another provider. Could you speak to that a
Mhm.
little bit?
Sure, yeah. So when someone comes in from the outpatient with and they have been previously seen by a palliative care team, whether it's ours or someone else's, um, we can pick up where they left off and continue the care. And especially with new hospitalizations, there's always new information and more decision making. So we want to make sure that we're part of that. And we often try and hand it back to your outside team again and make sure they understand kind of the course of disease and what was decided and what we discussed.
Great. Um, And then, so this all sounds wonderful. So I'm wondering, of course, all of us, I'm sure at home would be thinking about, is this covered by insurance? What is the cost
Mhm.
of this extra support? So Anna Marie, would you mind sharing, is this covered by insurance, or how does that
Mhm.
work if when it comes to actually getting the care?
Yeah, I would say every insurance is different. I think mainly if you have a Medicare senior plan, I think it's generally covered. And they accept major insurance companies with our outpatient clinic. So you can always call the clinic to see if they accept your specific insurance. Or I'm sure you could probably call your on the back of your card your insurance to see if something like that is covered. But for the most part, from what we've been seeing at the clinic, they sent us an email of accepted insurances, and it's major insurances that we cover. But you can always call to
Okay.
double check the office, and we always kind of screen a little bit too if we feel like a patient may benefit from our clinic referral. Sometimes, if we have an insurance question, we can call over to clinic so that we're not necessarily promising, oh, yes, for sure, you
Mhm.
could see our clinic and you're going to be seen by a provider. We'll do our due diligence to double check first before we promise anything, because if for some reason they don't accept our insurance, then obviously we have to tell them they not able to go to clinic if it's an insurance barrier.
Okay. Okay, that's good to know. And thank you for sharing how somebody can check as well, whether
Hmm.
that be on their card or reaching out. So
Hmm.
that's very helpful. And Stephanie, so I know we've touched on it here and there, but what would you say is really the main differences between palliative care and just regular what we think of as healthcare?
So, what I think really stands out for me about palliative care is that we are an actual interdisciplinary team of doctors, nurses, nurse practitioners, social workers, and chaplains. Um, it's not very common to see a team that has so many different disciplines, but the reason why we definitely want to make sure that we have all these different providers is because we're focused on whole person care and not just on your illness.
And then Anna Marie, kind of on the flip side of that, is what are the differences with palliative care and hospice?
Hmm. Yeah, a lot of people think hospice and palliative care are the same. And so a big difference is when we're talking about hospice, we're talking about someone with a terminal illness. However, they're not in any active treatment. And typically you're approaching end of life and that you have some sort of terminal illness. Usually with hospice, you're having a whole team support wherever you are. So sometimes hospice is at your home, it's at a facility, sometimes it's even here in the hospital, and so you're having that hospice team come to you. Generally, hospice is available by phone 24/7. The nurses are visiting you regularly, again, whether that's at home setting or at a facility. And the whole goal is to make it possible for you to remain in your own home with the hospice support. Um, Generally, the focus of hospice is providing that relief of symptoms for distress, to help with the family support. Um, and it really does provide the most support than what outpatient palliative clinic can provide, as far as home support. Usually, hospice is covered 100% by Medicare, and so it's covering the hospice team coming to you for support. It's covering any sort of supplies or equipment, but it is generally focused on comfort. With palliative care, we're talking about a serious illness, but we're focusing on improving your quality of life for both the patient and the family. We're talking about that extra layer of support in conjunction with your other teams, such as your palliative care doctor, your specialty doctors. And we're just helping to make sure that while you're going through this serious illness, that we're addressing your pain, your symptoms to kind of make sure you're having a good quality of life, but you're still in treatment. So someone with, let's say, cancer with palliative care, you could still get whatever's recommended, your chemo, your radiation. You're generally, coming to the hospital when needed. With hospice, we take away all that. We're generally um, just focusing on keeping you at home and keeping you comfortable is the main focus.
That's really helpful in how you differentiated the two. And then also, Stephanie, with the difference with palliative care and regular health care, because I think these
Hmm.
are ideas that a lot of us have heard of, or we're familiar with the terms, but not really knowing
Hmm.
what does that really mean. And I know one of the differences too. I mean, with hospice, it's generally there's this time limit of every 6 months somebody has to get
Hmm.
recertified. And
Correct.
Stephanie, I'm wondering, with palliative care, is there a time limit or a time frame that someone can receive palliative care services, or what happens there?
So generally, there is no time limit on how long a patient can receive palliative care services as long as they continue to have a qualifying diagnosis.
Okay. Okay. And then can someone go on and off of palliative care?
Yes, so we have patients who do feel like they've had their symptoms have been really well controlled and they're actually
Mhm.
doing a lot better. And sometimes they'll say, we don't need to come back to clinic right now. And then, their treatments change and they have other new symptoms. And fortunately, they can just go back with the palliative care team and resume some symptom management there.
Okay. I think that's helpful too, so that way those who are listening know just kind of how they can navigate this. And so thank you for sharing that. Another question for you, Stephanie, is if someone is needing support with medical tasks like medication management or wound care, or needs help with insulin. I know these are things that in-home care cannot support with because of that medical aspect. But I'm wondering, is that something that's appropriate for palliative care to help with those types of issues?
So palliative care can help with specific symptom medication management related to your serious illnesses. So such as kind of pain, nausea, constipation is kind of the main ones we work with. We do not manage wound care or insulin, but what we do is we work together with your home health service or your primary care provider to help with this care.
Okay. Okay, that's very helpful. And then Anna Marie, kind of the
Mhm,
opposite of that, and these are just questions that we get a lot from family caregivers when
mhm,
they're asking about palliative care or home health or hospice. Um, and so I want to make sure I bring them up here too. Is if somebody needs help with durable medical equipment, getting that, or they need in home care, or even things like meal
mhm,
prep, transportation, cleaning, laundry, is that
mhm,
something that palliative care generally helps with, or would that be someone else or a different entity?
mhm. Yeah, so generally palliative care doesn't provide kind of some of that home stuff that you're talking about. So we're not going to be in the home helping with light housekeeping or helping with the meals or laundry. We also don't provide any in-home caregiving. A lot of that is going to be something that you're paying for out of pocket. A lot of times, if you have a separate long-term care plan, sometimes that's going to cover some of that in-home caregiving support. Um, but again, as social workers, as a support, we're helping to assess kind of what resources you may need. So it's about connecting you. So if you're needing caregiver support, we're helping provide you and connect you to the right resources. If a patient is with clinic and is established, let's say a patient does end up needing some sort of supplies, or they end up needing a walker or a wheelchair, something, some sort of equipment, the doctor can write for those supplies and equipment, and even again some of those medications for medication management. But anything that has to do like in the home, I need a personal caregiver because I need help with dressing and bathing. Palliative care is not going to do that. It's going to be more of a paid caregiver to come in and provide that extra support. And again, the transportation, we don't provide that either. So that's again connecting you to some sort of resources to help you with the transportation.
Sure. That's very, very helpful because we do get those questions a lot, and it's something that's good for all of us to be familiar with too. So thank you for that. And just one more question for each of you.
Mhm.
Stephanie, do you have any recommendations for family members to help make palliative care services more successful? What would you encourage them, or what would you recommend?
So I always recommend, if it's possible, for family members to come in and join in with the visit. Palliative care discussions sometimes can be really complex, and at times it can even be overwhelming depending on what we're talking about. And it's always better to have what I call a second set of ears, kind of hearing the same information that you do. I also recommend note taking for family members who have patients who are undergoing medication adjustments, just because there may be some detailed directions. So it's always good for you guys to write stuff down. Um, Probably my third recommendation is if any of the patients and families have completed any documents discussing your healthcare wishes, we always recommend that patients bring that in. You've spent the time, you've completed it. we definitely want to copy and make sure that it's accessible in the electronic medical record for all your providers.
Very, very helpful. Thank you for that. And kind of similar question for you, Anna Marie, is what do you think is important for a family member to know about palliative care services?
Yeah, I think generally palliative care is underutilized, especially in the hospital. Kind of pre-COVID, a lot of times we were being pulled in like right at the end of someone's disease process, and helping with the severe pain and symptom management. I think palliative care is beneficial in really helping a patient and family member really understand their illness, their disease process, their options for treatment. Again, helping with those sort of specialty services of addressing your pain and your symptoms. Helping with that safety net planning to keep you safe at home, kind of what you're eligible for. A person doesn't necessarily have to be dying or at end of life to receive palliative care services. In fact, that's something I think that we're always working on is how can we get palliative care involved sooner. Um,
Mhm.
and again, palliative care is addition to work together with your other physicians and your treatment team. So we're just an extra layer of support to bring in as our specialty team to help coordinate your care, and work in conjunction with your other team members. We're kind of a specialty team as well because we're interdisciplinary. We have that uniqueness of having a physician, the PA, the nurse practitioners, our chaplain, our social workers, our nurses to all come together to provide that whole person care.
Beautiful. And so we've done these live streams. We had in-home care providers on one. We've had home health. We are now having palliative care. Later in the year, we'll be having some hospice providers. So really kind of giving this overview of what's available to the community, to patients and family caregivers. And some of my big takeaways from our conversation today is palliative care being very, very patient focused. This holistic whole person approach, in addition to, not instead of, this idea of having this continuity of care, and then really this emphasis on collaboration. So those are all really great things. And that's all the questions that we have. And I just want to thank you both for joining us this afternoon and for sharing such important information about palliative care services. And for those of you who've joined us in the audience, thank you. And we really hope this information has been helpful to you. We hope you'll join us again next month. We'll be having another live stream event, which will be Ask an Elder Law Attorney. It'll be a live Q&A where we'll be joined by an attorney who specializes in legal and financial planning. And we'll be answering audience questions as they come in and providing live responses. But again, thank you, Stephanie, and thank you, Anna Marie, for being here. And thank you, everyone who's joined us. And just take care and have a great afternoon. Thank you again.
Thank you so much.
Thank you.
Have a